blog has been one of my favorite to write, and it has very little to do with the content within it. It has everything to do with how I built my practice as an evidence-based provider. This is Brandon Steele with ChiroUp, and I'm going to explain to you how doing and performing the right treatment to the right patient at the right time creates an environment that you and your patient can prosper from. It has very little to do with the techniques and the education and the things that I know about that patient, and everything to do about knowing what types of treatments that specific patient can benefit from. The simple fact is that there isn't a single treatment for lower back pain, for cervical radicular symptoms, for plantar fasciitis, for tarsal tunnel syndrome. It's usually a multimodal approach that can help these patients. So when I looked at this blog as far as epidural steroid injections, I thought to myself that this one blog built my practice. And let me explain how. By shadowing a pain management doctor, by having continual lunches with medical professionals, with pain management physicians, with nurse practitioners, with physician's assistants about these kind of topics, that is what's built my reputation in my area. It's not about the techniques that I know. It's not about the school that I went through. It's not about my GPA. It's about the fact that I care and that I can understand what is the right treatment at the right time for that specific patient. And sometimes it's an epidural steroid injection. Now, epidurals have been widely overused. 2000 to 2009, there was an 87% increase in epidural steroid injections for a multitude of reasons we're not going to get into. However, we're seeing those numbers drop. And that doesn't mean the technique doesn't work, it just means it was overutilized. So when should we use an epidural steroid injection, and how should we educate our patients on why we're using that technique, both for diagnostic purposes and also pain relief purposes? So the first thing is, when should we even consider an epidural steroid injection? Simply, if we think there's a chemical component to that pain response. Chemical pain is constant, it's unrelenting, it's unchanged with position. Mechanical pain is the opposite. So when someone has chemical pain, that doesn't mean they need an epidural steroid injection, it just means they need a chemical for relief as compared to mechanical relief. An epidural steroid injection may work for that. In fact, if you have back pain that's been going on for 4 to 6 weeks, if it's non-responsive to conservative measurements, if there's evidence of structural deformation causing nerve root tension, and they have dural tension signs like a straight leg raise, these people can benefit from epidural steroid injections. It's not a long-term fix. In fact, most steroid injections last for symptom relief between 1 and 3 weeks. This provides an excellent window of opportunity to do what you do, to co-manage that case, to get rid of the chemical inflammation, and then provide the mechanical relief that changes the ADLs, building the capacity of that tissue, teaching them about their condition. Those are the things that epidural steroid injections can do. And from this blog, you can see they also do other things. In fact, total disability of patients decrease with steroid injections. Meaning if you're doing a cervical steroid injection, it doesn't mean it's only going to help the radicular symptoms going down the arm. It can also help with sleep quality, with headaches, with neck pain, with shoulder pain. So there's a lot of things that we can do to help that patient along their journey of pain relief. Now, there are side effects. In fact, most of the side effects are the people who've had multiple ongoing injections or surgeries, and convey that to your patients. This is not a long-term solution. This is a short-term fix. Now, the last thing that I want to convey to providers is that we can also use this for diagnostic purposes. And I, like everybody else, sometimes are a little baffled after a month on why something's not getting better. Doing an injection can help differentiate whether you have a central or intervertebral foramen type issue versus a peripheral type issue, an entrapment, a peripheral neuropathy. And injections can help in that process for those difficult patients. So by no means throw out everything you're doing and doing injections on everybody. We know that doesn't work, and it's not the standard of care, and it's not what I would recommend. Spinal manipulation, patient education, ADL modification, rehab, those are the things that work for most of our neck and lower back symptoms. However, sometimes you need, and your patients need, a window of opportunity to let them heal, and a steroid can help in that process. Thanks for listening to this blog. I love these kind of topics. We love to present that clinical information, but then also turn it into something you can use in your practice. So please never be afraid to refer someone out for epidural steroid injections. However, don't release them for steroid injections. Don't say they're in your care. Say, hey, we're going to do a steroid injection and I'll see you back on Monday after your injection. Co-manage those cases to help build your reputation as the best evidence-based chiropractor in your community.